There was a very interesting small study, only about 36 patients, called the SELECT study, which was stage 1 through 3 resected EGFR mutant patients who received 2 years of allotnib. At 2 years, they had a 94% disease-free survival rate, which sounds fantastic. But then they stopped the drug at 2 years, and at 3 years it had dropped down to about 60%, and by 4 years it had dropped down to about 40%. And the strong suggestion there is that the adjuvant use of these agents is not killing off these cells in the same way that chemotherapy in the adjuvant setting does. What it's doing is what we know it can do in the advanced disease setting, which is control the cancer. Now that means one of two things. Either maybe you're going to have to put these people on it for the rest of their life, which is unbelievably expensive, and then you have to think about what the side effects would be, or we're kind of missing the picture here, which is there are sensitive cells which are surviving this drug. We're good at controlling it, but somehow the sensitive cells survive, and unless we find targets other than just the things that drive growth, something that actually allows them to enter some kind of siege state to get through it, we're not going to be able to cure it. And some of the assays that we do to look for mechanisms of resistance, which is essentially growing cells in the presence of the drug and seeing what comes out, will not find those. They're designed to find mechanisms of resistant growth. We're going to have to do different assays, probably what's called synthetic lethal experiments, where you knock out genes and see what completely deletes a colony in the presence of the drug to find the things that allow you to maximize the kill rate. And until we do that, I think we shouldn't be giving these things in the adjuvant setting, because we don't yet know what we're doing and they're not increasing the cure rate.